Are the slides visible to everyone?
Yes.
Okay, perfect. So good afternoon, everyone. I hope everyone's well. My name is Megan and I'm presenting adverse events along with Dr. Fasati Gisela here. So adverse events. I'm sure none of us go about our day intending to cause harm to our patients, nor do we prescribe medication or perform procedures in the hopes that it will negatively affect our patients. However, as the old adage goes, to err is to human, and unfortunately mistakes do happen. I'm sure all of us have been post-call at some point and made a simple error that we wish we didn't had. So today's presentation will be about adverse events, how to identify them, and how to report them. Before we begin, we need to, okay, so this is just a table of contents, what we're going to be discussing today. So we need to define some terms before we begin. The first term we'd like to define is a clinical incident. This is any event that has caused harm or has the potential to harm a patient, visitor, or staff member, or any event which involves malfunction, damage, or loss of equipment or property, and any event which might lead to a particular complaint. So as you can see, this is quite a large umbrella term that encompasses many different aspects of healthcare. Most of this might not actually be applicable to us as healthcare workers. However, an adverse event is. An adverse event is a type of clinical incident where there is a negative and often harmful outcome to a patient. Now, there are many different definitions in the literature about what exactly constitutes an adverse event in healthcare. However, according to the Adverse Events Monitoring and Reporting Guidelines, initially defined by the KZN Department of Health and now used across South Africa, there are three things that are required for something to be defined as an adverse event. The first, negativity. It has to actually result in a decline in the patient's baseline function, whether permanent or temporary. Two, patient involvement. As we saw above, clinical incidents can involve many different types of people, including another staff member or a family member of a patient. But for an adverse event, for our particular definition, we are only looking at events that affect the patient themselves. And lastly, causation. This is perhaps the most debatable aspect of an adverse event and is not actually clearly well defined, as some sources state that you don't need to prove whether the incident had a causative relationship, and others reporting that you do need to prove it. Okay. So there are many different types of adverse events. Now, it's important to note that in all of these different categories, you can have preventable and non-preventable adverse events. For example, if we look in the drug category, an example of a preventable will be giving a medication to a patient with a known side effect which the patient then experiences. A non-preventable one would be giving a medication to a patient who is previously well with no known comorbidities and no known allergens. The medication you give is not a very well-known allergen, but the patient suffers an anaphylactic reaction from it. So adverse drug reactions, which is the first picture there, is perhaps one of the most common and the most reported on adverse event in our healthcare system, but there are many types of others. You can have a procedure event, which can be surgical or non-surgical. You can have diagnostic, which is failing to make a diagnosis or making the wrong diagnosis. Injuries, which can be patient-related, either you cause an injury to the patient or a patient cause an injury to themselves. Therapeutic, which can involve giving the wrong medication to a patient or failing to give medication correctly. Blood products reactions, and then communication errors, whether this is a communication error between you or the patient or between you and other healthcare workers. Obstetric and neonatal is often regarded as its own category, although it is related to all of the others. These are only some of the examples, and you can have many others. Okay. Now we know the different types of adverse events, we need to know how to classify them. Adverse events can be a spectrum, with some relating to minor or even no harm, and some serious. It's important to note the difference, as the serious adverse events are the ones that require more immediate emergent care, as well as more immediate reporting. So according to the National Guideline for Patient Safety Incident Reporting and Learning in the Public Sector of South Africa, and this report is substantiated by the South African Health Products Regulatory Authority. These are the 5 things that classify as a serious adverse event. If the adverse event results in death or is life-threatening, if it results in hospitalization or prolonged hospitalization, if it results in the abortion, a premature delivery, or a congenital defect of a child, if it results in permanent or temporary disability or incapacity, or is in any way medically significant. Now, the last point can often be quite subjective, as what I can deem medically significant, another doctor or another healthcare worker might not. And in fact, the guideline that I mentioned above, the National Guideline for Patient Safety Incident, found that before a guideline was put out, 8 out of the 9 provinces had a different scale than the one other province in determining what is considered medically significant. Currently, we use the Sac Guidelines. The Sac Guidelines, which stands for Severity Assessment Code, was initially established by New Zealand and has now been taken over by South Africa. It was initially released in 2017 with 3 categories, the 3 above, and these are the 3 that we currently use in South Africa for reporting. However, New Zealand released a new updated version in 2010, which consists of 4 guidelines. The 4 guideline one is not currently in use in South Africa, but I'm going to go through the definitions of the 4 guideline as they're easier to understand. So a SAC 1 is something that results in death or permanent severe loss of function. For example, the wrong limb being amputated. A SAC 2 is permanent major or temporary severe loss of function. Example, a medication error resulting in acute dialysis being needed. So if you give a nephrotic antibiotic. A SAC 3 is a permanent moderate or temporary major loss of function. Example, a fall of a patient resulting in laceration, which requires suturing. And a SAC 4 is something that requires temporary, less than 1 day, advanced level of care, or no injury, and this includes a near miss. So example will be a medication error with no resulting harm. So why does it matter? Why do we care about adverse events, and why should we be able to identify them? According to the KZN guidelines, 8 to 12% of all hospitalizations globally include adverse events, and it is the 3rd most leading cause of death in hospitals worldwide. So as such, I'm sure we can all see we would want to prevent them. We'd want to make sure that we do not cause adverse events and learn from them. So in order to do so, we need to have a report system in how to know when an adverse event occurs and how to prevent it in the future.
I'll be taking over from here, thank you. Prevention of adverse events is actually one of the final steps in the management of adverse events. And this management protocol can be broken down into a simple 9-step algorithm as taken from the patient incident reporting guidelines. Not all of these steps involve us as interns, but knowing how the process works is very useful, as it is likely you'll be involved in more of these steps the more senior you become. Management begins with the identification of an adverse event, which may be by yourself, or via a patient or family complaint, a lawsuit, a retrospective clinical review, etc., etc. Any of these pick up on something wrong. While experience and gut feeling are helpful, the most useful tool to identify adverse events is knowing what constitutes one, as Dr. Derwin described earlier. Once identified, the next management step is the immediate action to mitigate the consequences of the adverse event and understand how it occurred. To do this, one performs damage control to assist those involved in the adverse event. One ensures that others are safe from its effects, and one gathers information from those involved or those who witnessed the event. This is later all important, especially in the next 2 steps. Thereafter, we have the prioritization of the event, which ties in with notification. So when we look back onto the severity assessment code, next slide, please, as described earlier by Dr. Derwin, we have code 1 events, which was the major loss or death. They have to be reported to the district or the provincial management within 24 hours. But code 2 and code 3 events only need to be reported to management of the facility where the event actually occurred. Next slide, please. In order to report, we use this form, which is the Patient Safety Incident Reporting Form. It has 2 sides and it's usually not as nice and colorful. As you can see, there are 3 little blocks in the middle, and that is where you will choose your severity assessment code, heavily depending on what occurred. This form needs to be filled out by as many people as possible relating to an adverse event. It has many demographics, as you can notice. And then next slide, please. It also shows that you should be detailing the incident details from your perspective and those of others. Next slide, please. Once the incident has been notified, it is investigated by the code-dependent regulatory body, so either Code 1 or the Code 2, Code 3, is then classified accordingly and analyzed to glean insight into the factors that may have attributed to the adverse event. From this information, the regulatory body will then make a recommendation in order to prevent further adverse events. These may include adding safety precautions, changing infrastructure, teaching, or even nothing, in the case that they find nothing could have been done to prevent it. Finally, adverse events are great teaching moments, as they embody the sentiment of learning from your mistakes. And even though it seems like this is a fairly newish topic, we've all listened to hundreds of them being discussed in M&M meetings. Next slide.
So there are a few resources we came across when researching our topic that can help you. So although currently there's no online reporting system for all adverse events in South Africa, there is the SAPRA Med Safety app, which is designed by the South African Health Products Regulatory Authority. And you can use this to help report drug-related adverse events. They then create a database and then a guideline for us to help prevent further drug-related events. Vigi Access is a similar type system. It's a WHO-funded platform, unfortunately not an app, it's a website, but you can check drug and immunization-related adverse events on it. So if you give a drug to a patient and they have a side effect that you're not too sure can be related to the drug or not, by going onto Vigi Access, you can make sure if it is. And then I'm sure most of us have EMG guidance already established on our phones. They actually have a built-in interaction checker on it. So if you would like to give a drug to a patient who is already on medications for whatever purpose, you can type in all the different types of medication the patient has, and it will tell you whether those medications will react or not to help you prevent any reaction. Okay, so these are just our references. So the different guidelines you can see are all the underlined ones. And then on the next slide, the bottom. Okay, I don't know where it went, but there was a link for the New Zealand Sac Guidelines that help break down all the different examples into which category they would go to. It's on here somewhere, I just can't find it. Okay, thank you. Are there any questions?
Thank you. Any questions? Any comments? Anybody would like to add anything here? Dr. Aki, anything? I think you covered it fine.
Yeah, I think she has covered most of the things.
Yeah.
However, the only one comment I can add is that what you will notice is that there are a lot of these adverse events that go unnoticed, whether by design or lack of awareness. So the point of this exercise is to raise awareness that a lot of things are happening in our midst. So unless you pick it up, it can always be ignored. The other thing that you will realize is there are times when, you know, some of our colleagues feel, they don't understand why they should report some of the adverse events. So there is a tendency to cover up some of the events, and you'll realize it in the way, clinical notes are being written. You just do a little bit investigation, and then whatever is written in the patient's notes does not really make sense. So you begin to realize people are afraid of reporting events because they feel that they might be found culpable, and so on and so forth. So that awareness needs to be out there, that the exercise is about prevention, and also learning from the mistakes that we make during our practice. It's not about victimization as such, but about protecting the people that we are looking after. So therefore we need to be as honest as possible and try to encourage others as well to be on the lookout for some of these, adverse events. Thank you, Prof.
Thanks. I think it's part of a conversation around patient safety And in fact, the WHO has brought out policies around patient safety, and it is broader than, it's very similar in some sense to this kind of the broad issue. I think the problem, as you pointed out, Dr. Aki, is that at the moment it's just drug adverse events that are even reportable or not even mandatory, but just available online to provide that background information. So that's a big problem, and it forms part of a bigger problem about quality management in the health system, that we don't know whether we're giving quality broadly within it. So quality and patient safety are big issues that need to be considered. So there's a whole movement around the world, particularly because many of the managers, non-medical managers, have been finding themselves unable to address the clinical quality issues and some of these issues, and are pushing, starting with the UK, around the concept of clinical governance. So you might hear of this as well in Joburg and in Gauteng. There have been clinical governance forums being formed, spaces where clinicians have been trying to push the idea that we need to look for quality, look for patient safety challenges across the board, and be able to do it more proactively than simply wait for someone to bring it to notice. So there are avenues for that to be managed. Anybody would like to tell me what are the ways in which they would think this is being managed? Commonly, would you been seeing that happen? That one should be getting places where clinical governance, and that's usually review of information, is done. Anybody would like to say, how do we actually commonly manage quality and safety in the clinical context? What we
Prof,
talked of
can
with
I make
clinical
a
governance.
comment?
Yes, go ahead, Maggie.
Yes. It's not a difficult process, and I think people, because they don't know what is the process, and especially the young doctors, that's why probably some of these events are not noticeable and just get covered up and never reported. So if you cannot find in your clinic the form for the adverse event, go to the pharmacy. Our pharmacists in the CHCs are not far away from our consulting rooms. So go to pharmacy and tell them, I've got a patient who reacted to this and this medicine. Can I please have the form? They will give you the form immediately. Just complete the form and give it back to the pharmacy. So that is the way you should do it. Not just to keep it into the file of the patient or give it to the facility manager. No, you go to the pharmacy and drop the completed form there, and they're going to forward it further to the relevant institutions where this information is going to become a statistical data. So it's a very easy process. Only you need to know how to do it, and the form is easy to complete. Okay.
Good. And so just if you have an incident like that, adverse event related to drugs, just go to the pharmacy, ask them for a form or provide them information.
Yes.
Good. And then those usually come up to the PTC, which is a Pharmaceutical Therapeutics Committee.
Exactly.
And that is one of the sort of clinical governance ways where you gather information around, some of these quality safety issues. Sometimes pharmacists can actually pick up, high use of antibiotics, which represent a failure in quality and safety, or polypharmacy. There's some of these things that can be picked up. Some of these PTCs include lab investigations, perhaps wastage, unnecessary use of drugs, which is more cost effectiveness than safety, but it is part of quality. Usually the other is the M&M, where people have M&Ms. It's a space where you can do that. Now, many times in primary care, that idea of mortality is not big, but morbidity is. Near misses, referral challenges can be part of that kind of discussion. And we do have quite a few of that happening from primary care upwards, and one can collect data at the moment, it's not very rigorous. So you can find ways to measure quality as well there. You got also lots of information floating up, which is from primary care using the district health information systems. Sometimes that shows also quality challenges where, for example, pap smear rates are very poor, family planning use is poor, condom usage is poor, HIV testing is poor. That kind of thing tells you also about quality. It's how you can improve clinical governance. So, and you may also do audits yourself on elements of care using guidelines and looking at what should be established quality, and then saying it's not actually up to scratch in a particular facility or a set of facilities. So you have all of this potential to implement clinical governance, which includes quality and patient safety, and in which adverse events form part of. Any other questions? None? Good, thank you.